오늘의 첫 번째 순서, 2일차 첫 번째 순서는 하버드대학교 로버트 시걸 교수님이 징후관리를 넘어서 만성통증 완화를 위한 마음챙김 재활 수행에 대해 강의를 해주시겠습니다. 큰 박수 부탁드리겠습니다.
Thank you, everybody. I'm happy to be here. I would like to thank everybody at Dankook University who helped put this together, and particularly to thank the SIMF committee and my friend Sunim, who helped to connect me to everybody there so that we could all be together. I'm going to talk today about mindfulness as a treatment for chronic pain along with rehabilitation. And I'm a clinical psychologist here at Harvard University, and you may wonder how a clinical psychologist got involved in pain treatment. Well, I actually began as a patient. It was some 30 years ago when I spent 4.5 months flat on my back with a herniated disc diagnosis, and I was not happy. I was in a great deal of pain, and in those days, the typical medical advice and the advice that I received from the famous doctors here at Harvard Medical School was that I should spend as much time horizontal as possible, and hopefully the disc would heal. But if it didn't, I could be a candidate for surgery, but surgery had a very uncertain outcome. So it was not a good diagnosis to have. But I followed the doctor's orders, and I was lying down regularly, and I wasn't getting any better. At one point, my wife, who's also a clinical psychologist, she said to me, "You know, Ron, you seem to complain more of the pain every time we have an argument." And I thought, oh gosh, this is the price I pay for marrying another psychologist. Here I have a clear orthopedic disorder, and she's interpreting it. Worse, she's interpreting it psychologically in the context of our relationship. Well, I just kept on lying down. And at a certain point, I realized that as a psychologist, I had a pretty sedentary profession. So perhaps I might try having friends of mine and colleagues construct basically a platform bed or a couch, both in my clinic office and in my private practice office. And they did that. And I began a bizarre parody of the classical psychoanalytic scene. My patients were sitting up, I was lying down, and they were wondering about my prognosis and my pathology. This dragged on for weeks until a fellow at work named John said to me, "You really should speak to Linda. She knows a lot about this." Now, Linda was a clinical social worker who ran a residential treatment facility for young adults. And I thought, what could she possibly know that the Harvard doctors don't know? But John was insistent. So one day I called Linda to ask for her advice. And the first thing she said to me was, "Oh, hi, Ron, I hear you have a back problem. What are you doing?" And I said, "I'm lying down. It's all I ever do." I was not a very friendly person at the time. She said, "Why don't you get up and buy groceries? Your wife will appreciate it." Now, I'm a postmodern man. I'm happy to go to the grocery store and buy groceries, but I couldn't even walk. How could I possibly buy groceries? My experience up until that day was if I walked more than about one city block, I would get terrible pain shooting down one of my legs. But Linda insisted, just do it. Just get up and start moving. So I had an appointment with the surgeon a few weeks further down the road. And I thought, before I see the surgeon, I'll try doing what Linda said. So I tried walking. And indeed, I walked my one city block, and as I usually did, I got pain shooting right down my leg. And I thought, I'll try going further. I walked a second city block, and to my great surprise, not only did I have pain down the first leg, but I developed pain going down the second leg. So I thought, oh, that was great advice. Now I have pain down two of my legs. But actually, it was great advice, because according to the CAT scan, they weren't using MRIs in those days. It was just CAT scans for imaging. According to the CAT scan, the disc was herniated laterally, as they usually are. So I was supposed to have pain down the first leg. I was not supposed to have pain down the second leg. I thought, what could this mean? My first hypothesis was, now I've shattered my spine entirely and I'll never be able to walk again. But my second thought was, maybe Linda was right, because Linda's hypothesis was what was then a crazy idea, which was the vast majority of chronic pain disorders are not actually due to structural damage, particularly to the back, but rather they're due to patterns of stress and fear that tightens muscles and causes this kind of pain disorder. you know, it was just crazy enough that I thought, maybe this is what's going to happen. And I decided for the next 2 weeks to treat this as though it were a psychophysiological disorder. That means a disorder caused by a state of mind which changes an organ system in the body, in this case, tightening up the muscles, and that causes the symptom, in this case, the pain. And 2 weeks later, I was better. I was sitting up to see my patients. I was walking long distances. I was starting to do yoga again. Now, interestingly, I had been a meditator ever since I was 17 years old, but you don't hear much about meditation in this story. I was so depressed and so discouraged that I thought, what's meditation going to do for me? Once I recovered from this and realized what the dynamics were, the mechanisms that caused this disorder, I realized mindfulness practice would have been a perfect intervention. And what I'd like to share with you now is how mindfulness practice can be a perfect intervention for this and other kinds of pain disorders. So we're going to start by talking about chronic back pain because it's such a good example of how these practices can help with a disorder that seems to be purely orthopedic, but turns out to have a very big role for the mind and our behavior. As a patient, when you go to see the doctor and you have chronic back pain, usually they'll do some kind of imaging, and usually they'll find something wrong with the spine. And very often we're told that the spine consists of this series of bony vertebrae separated by a cushioning disc. And in the United States, the way that disc is described is as though it were a jelly donut, a structure that had a firmer outer part and a very soft inside. And with wear and tear and over time, that soft inside can push out through a tear, press on a nerve, that's the yellow structure you see here, and cause pain. The other thing that you're typically told is the orthopedic story. This says that we evolved originally to walk on all fours. As primates evolved into various kinds of the Homo subspecies, and we became Homo habilis, the tool maker, we began using tools, walking upright, and we began to adopt all sorts of ergonomically unwise postures. And the model that's given is the reason why there's such an epidemic of back pain in the world is because we're not using our bodies correctly and because we evolved to have this problem. They say that standing upright puts tremendous pressure on the discs, and that's the culprit. Well, it turns out that there is an evolutionary problem at the heart of this, but it's not this evolutionary problem. It's a different one. So what's the evidence for this? I will just give you a few of the research studies that are helpful to know about because they're so helpful to free us from being afraid that there's structural damage in our back, which is causing the problem. A classic study, this study is now over 25 years old. They did MRIs, magnetic resonance imaging, up and down the spines of some very unusual people. These were people who never had any back pain in their life lasting for more than 2 days. And that's only 20% of the population that fits that criteria. And what they found was that 2/3 of these people had at least one bulging or herniated disc. In fact, 1/3 had 2 or more bulging or herniated discs. So these are structural findings that look abnormal in people who have never had any pain at all. Then we have millions of people who suffer from chronic back pain who show no abnormalities in their backs at all. They go from doctor to doctor, and every time they get the same report, your spine looks fine. I don't know why you have this problem. And then finally, there are millions of people who have surgical repair. The only problem is the pain doesn't go away. So they go back to see the surgeon, they do a subsequent MRI to see what might the problem be, and the surgeon says, your spine looks great. The surgery cleared up the problem in the spine. I don't know why you're still suffering with pain. Well, why might this be? These studies all suggest that there's a very weak correlation between what we find in the structure of the spine and whether or not a person is in pain. So we have smoking gun studies. Would you care to guess what countries have chronic back pain epidemics? Well, you probably know one of them. Korea is one. So is the United States. In fact, the entire Pacific Rim is involved. All of Western Europe is involved. Australia is involved. Although there's an interesting case study that came out of Western Europe in 1989. I don't know if any of you remember what happened in 1989 in Western Europe, and particularly in Germany. There was something called the Berlin Wall, which came down in that year. And prior to 1989, the East Germans, who, by the way, did not have access to highly sophisticated medical care, had a very low incidence of chronic back pain. But the West Germans had a high incidence. After the wall came down, 2 years later, the East Germans had the same high level of chronic back pain. They had actually caught it from the West Germans as though it were a communicable disease. But of course, it wasn't the disease that was communicable. It was the idea that the back is vulnerable and needs to be treated carefully that they caught from the West Germans. You may wonder who's going to get chronic back pain. There have been a number of prospective studies, meaning studies that look into the future, to see, for example, there was one done at the Boeing Aircraft Company where they looked at thousands of employees and tried to determine who would eventually develop chronic back pain. You want to take a guess? What was the most common risk factor for it? It didn't have to do with whether people were sitting for long periods of time. It wasn't about whether they were working on airplanes or lifting heavy things or even whether they were driving long distances in a car. The best predictor for who would develop chronic back pain was job dissatisfaction. People who didn't like their jobs got back pain. And if you've ever not liked your job, you know it's a source of a lot of stress. Finally, we know that the quickest way out of acute back pain is a rapid return to exercise. So what's going on here? What's causing all this pain if it's not the structures of the back? Well, it turns out that it is largely the result of stress. And when we talk about stress, we're talking about two things. We're talking about the activation of the sympathetic branch of the autonomic nervous system, and we're talking about the activation of the HPA axis, the hypothalamic pituitary adrenal axis. We don't have to get into the scientific details about exactly how these work. Let's just see how this stress response system works in a well-functioning individual. Now, unfortunately, I was not able to find a well-functioning human, a well-adjusted human, to be able to describe to you. But this bunny rabbit happens to be very well-adjusted, so we can look at his experience. And I'd like you to imagine that he is sitting on this field of grass, quietly munching the grass and enjoying his lunch. And let's imagine that in the far corner, he sees a fox. He's going to have a very predictable set of psychophysiological responses. His ears are going to orient toward the fox. Bunnies are very cute when they do this. The hairs in his body are going to stand up because the little muscles at the base of the hairs are going to pull downward, causing the hairs to stand up, and that's to make him look big and ferocious. If you think that's funny on a bunny, that's what's called our goosebumps, the little bumps that we get on our bodies when we're frightened. His heart rate is going to go up, his respiration rate is going to go up, his body temperature is going to go up, and of particular interest to us here, all of the skeletal muscles in his body are going to tense because he's getting ready to either fight, run away, or freeze in his position. Now, we know that bunnies are not particularly big fighters, so he's basically going to freeze and then run away. Now, if the fox were to wander off, the same bunny would have another very predictable set of psychophysiological responses. Basically, everything would return to baseline within about 20 minutes. But of course, this bunny is a poor, primitive creature who has none of our sophisticated capacity to plan, to analyze, and to think about the future. If he had a brain that was sophisticated like ours, he would be able to think, I wonder where the fox went. Maybe the fox went to the next field where my wife and children are. Perhaps the fox went over back to his den to tell his friends about me. Damn. And if he were really sophisticated, this bunny would think, gosh, do I have enough savings in my retirement account to make it through old age? And other kinds of worries. Now, what do you imagine would happen to his fight or flight system, to his emergency stress response system if he had all these thoughts? It would get stuck on because that's what happens to us. Every time we have a frightened thought, we have adrenaline going through our body again, and we have more stress and more tension. So that leads us to fall into what's called the chronic back pain cycle or the chronic pain cycle. And if we can understand how this chronic cycle works, we will be able to understand how mindfulness practice might be able to intervene in the cycle and interrupt it. Many times where I live here in the Boston area of the United States, sometime around December, people start to do a strange activity that they hadn't done for many years. They start to move their body like this because the snow comes down and people start to shovel snow. And very often their backs will become sore. This leads, if you can see on the slide, we're starting in the upper right-hand corner, starting with injury or soreness connected with an activity. Perhaps I can point to it here. And then this here moves to a sensation of back pain. Now, if we are so unfortunate as to live in a country that has an epidemic of chronic back pain, it's going to lead to some negative thoughts. Now, it's very interesting, if I may add here, to consider which countries have chronic back pain. I mentioned the ones that do. It's all of the economically developed countries. But you know what? There are countries that don't. And those countries tend to be in the less economically developed part of the world. In fact, the WHO, the World Health Organization, did a study years ago and found that the lowest incidence of chronic back pain was actually in Africa, and particularly in Nigeria. And there it was the poor rural farmers that had the least back pain. Now, that wouldn't make any sense if the cause of the pain were not taking good care of your back, because they do not sleep on top of the line orthopedic mattresses. They do back-breaking labor in the developing world. They don't have access to medical care, and certainly not to imaging. And yet these people have a very low incidence of back pain, while those of us in the developed world have a very high incidence of back pain. So if we live in a country with a high incidence of back pain, like the United States or like Korea, and your back starts to hurt, you're going to start to have some negative thoughts about this. You're going to start to think, I hope I didn't injure myself. I hope this is going to get better. I hope I won't be disabled the way my uncle, my aunt, my patients, other people I know are disabled. That frightened thought, which again is made much worse if we live in a culture that already has an epidemic of this, is going to lead to certain predictable negative emotions. So if you look at the diagram here, the negative thought will lead to these negative emotions. And the emotions will be things like fear, anxiety, and anger or irritation. And to understand the effects of this on the body, I would like you to join me in a little exercise. I'm going to count to 3. And when I say 3, I want you to show me in your body what fear looks like. Imagine that you're in an acting class and you want to show in a very dramatic way what fear looks like. Okay? Really do this. Join me in this, please. Ready? When I say 3, we're going to show fear. 1, 2, 3. Thank you for joining me. Okay. Now I'm going to count to 3. And when I get to 3, show me what frustration looks like. Because very often chronic back pain problems are frustrating because the doctors aren't very helpful about it. So we'll do frustration. Ready? 1, 2, 3. Excellent. Now I'm going to ask you to join me in a little more acting. When I count to 3, I want you to show me what anger looks like, because many of us become angry under these circumstances. It's very annoying to have this kind of back pain and to have it so that the doctors don't seem to be able to help us. Ready? Let's all do anger together. 1, 2, 3. Okay, some of you are not joining me. Thank you, those of you who are. What was happening to the skeletal muscles of your body in all of those conditions? They were tensing up, right? You feel tension in the muscles of your body. Now, join me in the diagram here. So we have tensing of the muscles. Now, tense muscles actually create more back pain. Have you ever had these muscles tighten up? They hurt, right? Have you ever had your calf muscle tighten off? We call it a Charlie horse in English, a cramp in your calf muscle. It's extremely painful, even though it's harmless. So the muscles start to hurt more. That's going to bring more negative thoughts. I'm thinking it's getting worse, not better. I really have injured myself. more negative emotions, more tension, and you could see how we could get caught. You could see how we could get caught in this cycle. Almost everybody, after a little while, starts to restrict their physical activity. They think, I don't want to injure myself further, so I'm going to stop doing exercise. I'm going to stop doing yoga. I'm going to stop doing the things, interestingly, that I used to do to feel less stressed. That simply adds to even more tension, feeds into the cycle, and it keeps going. After a while, you lose strength, you lose endurance, and you lose flexibility. The muscles actually become vulnerable, and you become irritable and depressed. I've worked with patients who were stuck in this cycle for a month, a year, 10 years. I've had 2 patients that were stuck in the cycle for 40 years, believing that they can't use their bodies normally, who once they understood what was going on and took up some mindfulness practice to help, they went back to full lives. One of them, when they were in their 60s, one in their 70s, they both went back to playing tennis because they became confident that they could use their bodies normally. Now, mind you, we started this cycle up here in the upper right-hand corner where my cursor is, with injury or soreness connected to an activity, in this case, shoveling snow. It can also simply start from stress in our lives. We can be going through a difficult time, which is stressful, and that can cause the muscles to tense. And those tense muscles can cause the back pain, and that can cause the negative thoughts, and we can get stuck in it that way as well. In fact, at least 50% of people who develop chronic back pain never had any precipitating event at all. They never did anything physical that could possibly explain it. They were simply living their lives normally, but the pain seemed to come out of nowhere. So how might we treat this? How might we use rehabilitation and mindfulness to treat this? The first and most important thing is to realize and to tell our patients that we understand that this is not imaginary pain. This is a psychophysiological disorder. And for those of you who are in the mental health field, let me distinguish between a psychophysiological disorder and a conversion disorder. Conversion disorders are what Freud began psychoanalysis to treat. Things like hysterical blindness, hysterical paralysis. These are situations in which the body is working normally, but because of an unconscious process, because of something happening in the mind, the person experiences their arm as though it's paralyzed. They experience their eyes as though they can't see, or that they don't have sensation in the body. We're not talking about this here. We're talking about psychophysiological disorders in which a certain belief and a certain mindset leads to emotions, and these emotions change the functioning of the organ system. They actually make the muscles tight, and it's the tight muscles that create the pain. So when talking to patients about this, we really want to emphasize that we understand that the pain is not imagined. The pain is not just, quote, all in the head, close quote. It's due to muscle tension, but behavior and attitude toward experience is what's tightening up these muscles. It's caused by very real muscle tension, but patients need to hear this repeatedly. And then we're going to use a 4-step process employing mindfulness to help free people. We're going to start with a medical evaluation. I've been talking about the most common cause of chronic back pain, which is not structural damage. But of course, there are times where chronic back pain is caused by a structural damage. There are herniations, for example, of the disc that are very massive and really are causing the pain that people are experiencing. There are times, for example, when people could have tumors of the spine, whether malignant or benign. There are metabolic disorders that can cause this. There's all sorts of physiological problems. So we have to start with a medical evaluation. Just as it's considered very bad practice as a psychologist to psychoanalyze a brain tumor, we certainly wouldn't want to treat this as though it just needs mindfulness and rehabilitation if there's an underlying medical condition that needs to be treated. The question to ask the doctor, and this is important because people often don't ask their doctor this, is, doctor, do you have good evidence that if I were to use my body normally, I would cause irreparable harm? That's the question. The question is not, will it hurt me to exercise? Because it may hurt. It may cause pain to begin exercising. The question is, will it damage the tissues of my body to start exercising? It's very important to differentiate the question that we're asking here. And so we need a medical evaluation which gives us permission to move freely. Once we get permission, then we're going to work with cognitive restructuring, which is really changing people's model for what's wrong, helping them, instead of thinking, oh my God, I have a ruptured disc, or oh my God, I have spinal stenosis, to begin thinking, how might I be stressed now? How might psychological factors be contributing to this? And what might I do, including my use of mindfulness practice, to work with those stressors? The third phase is going to involve resuming normal activity. This is the rehabilitation phase of our project, and I'll give you an idea of how we do that. And the fourth phase is finding a way to use mindfulness practice to work with negative emotions, because very often what's causing the tension in our body is we are afraid of some feeling. If something makes us angry and we're not comfortable feeling anger, or something makes us frightened and we're not comfortable feeling fear, or something makes us sad and we're not comfortable feeling sadness, our body will tense up to resist this. And this is one of the ways we're going to use mindfulness practice, because mindfulness practice, particularly open monitoring practice, can allow us to permit all of the various emotions that arise in consciousness to come into awareness and come out of awareness fully, so we're no longer tensing up trying to get rid of them. So let's take these steps beyond the medical evaluation to look at how mindfulness practice can help. But first, I want to do a little bit of a detour and explain one of the insights that comes from mindfulness practice here. I don't know where those red lines on the slide came from, but I'm going to just stop the share and start again to see if we can get rid of them. Here we go. Now, the Buddha, interestingly, was an early pain treatment specialist. And one of his sutras is translated into English as the story of two arrows. And what the Buddha said in this sutra is the following. He said, when touched with a feeling of pain, the uninstructed, run-of-the-mill person sorrows, grieves, and laments, beats his or her breast, becomes distraught. So the person feels two pains, physical and mental, just as if they were to shoot a man with an arrow and right afterwards were to shoot him or a woman, her, with another one, so that the person would feel the pains of two arrows. This is going to be critical in the use of mindfulness practice to work with pain. The first arrow is the moment-to-moment sensations of discomfort in the body. The second arrow is our protest against it, the way in which we tighten up, get angry, become frightened, and try to get rid of the pain. Interestingly, I was explaining this once to a patient here in the Boston area who worked at the Massachusetts Institute for Technology, MIT. And he said, as people who work at MIT frequently do, he said, there's a mathematical formula for that. And I said, what might the mathematical formula be? And he said, it's pain times resistance equals suffering. So let's look at this together for a moment, as though it were a mathematical formula. If pain is very, very high, we've literally been shot by an arrow. Even if we can get our resistance down low, we're still going to suffer, because we'd have to drive the resistance down to zero before we could really not suffer. But very often, pain is in a moderate zone. For example, where I live here in the United States, in a month or so, the weather's going to get warm, and I might be sitting out on the porch, enjoying a summer's evening, and I will begin to hear a sound. And I'll start swatting the mosquitoes away, because mosquitoes are frightening and annoying. However, I remember an early meditation retreat before we had problems with diseases being carried by mosquitoes. We have some problems with diseases now here, but before we had those problems, the instruction that was given at the meditation retreat was just don't kill anything. And should a mosquito bite you, simply experience the mosquito biting you. And I would be out there meditating. I remember the experience with my eyes closed, and I start to hear the sound. And you know, it's the moment when the sound stops that the trouble starts, right? And sometimes I could actually see the mosquito right here on my hand. And I could see it drill a little hole with its, I believe it's called the proboscis, the front part of the mosquito, inject an anticoagulant, and then begin sucking the blood. In fact, the back part of the mosquito gets large. It turns into a big red bulb, and then the mosquito would fly away to use the blood meal as protein to be able to lay eggs. And the whole experience, taken as a mindfulness practice, it's fascinating. It's like having your very own nature film happening right here. It's actually not even very unpleasant. But once we start fighting it, if you've ever gone camping and you're in the tent and you close the zipper and you start hearing the sound again, you know that it can be terribly aggravating and terribly upsetting. So very often, pain is actually in a moderate zone. After all, the pain caused by a mosquito bite is not very large. But because our resistance is high, because we hate it so much, we suffer a great deal. So this leads us to the conclusion that pain is inevitable in life because things are going to happen that make the body hurt, but suffering is optional. And suffering includes the grimacing, wincing, and bracing, all of the aversive thoughts. I hate this. When is this going to stop? The wishes for relief. I need medicine. I need somebody to make it stop. The self-punitive thoughts. I never should have shoveled the snow. This was a terrible idea. It's all my fault. And the anger, fear, and depression regarding the condition. We know that people who are in chronic pain very often become depressed. They start to feel hopeless and helpless. And what we can do with mindfulness practice is we can begin to separate these two arrows. We can separate the moment-to-moment sensations of pain from the resistance to it. And we discover that we can actually learn to relax the resistance. Now, there have been some fascinating research studies about this, and I want to just share with you a few of them. In some studies, they use experimentally induced pain. And this means that they purposely cause pain for the patient or for the subject. Sometimes the pain is caused by immersing the hand in ice water. Sometimes the pain is caused, if the person is in a functional MRI machine, the pain is caused by applying an electric shock or a heat laser to the feet. And there are some general findings that have come up over and over in these studies. Compared to novices, compared to people who are new to meditation, experienced meditators find pain to be less unpleasant. They can observe pain less reactively. In other words, they don't tense up as much every time they feel the pain. They find that open monitoring, allowing sensations to come and go freely, reduces the unpleasantness of the pain, and they have less anticipatory pain anxiety. This last part is particularly important because in studies of pain, it turns out that it is anticipatory pain anxiety that leads to disability. It's the thought that if I do this activity, or I do this movement, or engage in this posture, that is going to cause me pain. And because of that, I avoid doing it. And my life becomes narrower and narrower and narrower, and my muscles become deconditioned. I lose strength, endurance, and flexibility. So to understand this, one of these studies, which I find particularly interesting, I just want to say a few words about neuroanatomy. The insula, and you see a picture of a diagram of it there on your screen. The insula is a brain structure which is associated with interoception. Now, the brain is fantastically complex, so all structures have many, many functions, but one of the central functions is indeed interoception. It is active when we have visceral and gut feelings, and it processes transient bodily sensations, and we know that it's activated during meditation practice. We also know from an early study, one of the first studies of the effects of meditation over years on brain structure. This was a study done by my friend and colleague, Sarah Lazar, here at Harvard Medical School. She discovered that people who had been meditating for many years, including up to decades, had larger insulas than people who had not. There was actually parts of the insula that grew when people meditated more. And it makes perfect sense. In most forms of meditation, particularly mindfulness practice, we're paying attention to the interior sensations in the body, right? The Buddha taught mindfulness of the body as the very first foundation of mindfulness. And if we're paying attention to the body, we're actually strengthening those neural circuits that connect to sensations in the body. Now, another part of the brain to mention is the prefrontal cortex. This is an area here, and that is involved in evaluating emotional responses and regulating emotions. It's basically an important part of the thinking and evaluating and analyzing part of the brain. So the prefrontal cortex was active for our ancestors when they were out there on the African savanna, and they would see, let's say, a beige or yellow shape behind some bushes, and they'd say, oh, it looks like a lion. So they would get frightened, but then they think, oh, but lions aren't found here. So it's probably a beige rock. This capacity to think actually can allow us to disengage sometimes. However, the same capacity to think is the one that you saw in the chronic back pain cycle, has the thoughts of, oh no, maybe I've injured my back. Uh-oh, I hope I'm not going to be disabled. I hope I'll be able to recover from that. All of those fearful thoughts that come about actually come from the activation of the prefrontal cortex. So now that you know a little bit about brain anatomy, I want to mention what happened in this study. In the study, they took people who were new to meditation and people who were experienced meditators. And what they did was they subjected all of them to a heat laser. They basically applied this painful stimulus to their feet. And it was the feet because their head is in the MRI machine, so the feet are sticking out so they can apply pain there. And it turns out that when the meditators were given the heat laser, were subjected to the pain, they had increased activation in the insula, the part of the body, the part of the brain, which processes interoception, sensations in the body. And they had more activation than the non-meditators did. On the other hand, the meditators had less activity in the lateral prefrontal cortex, in part of the prefrontal cortex. So in essence, they had less of the reactivity to the pain and less of the thinking about the pain. They weren't as filled with thoughts of, I hate this, how long is this going to last, when is this going to stop? So what we saw in this neurobiological research was actually a validation of the sutra of the two arrows. We saw that people who meditate regularly are able to feel the first arrow. They're able to experience the pain in their body actually quite vividly, but they don't get caught in the second arrow. They don't get caught in fighting it and hating it. And the very interesting finding from this was that when these meditators and the non-meditators were asked to evaluate their pain level, and the typical way this is done is on something called the visual analog pain scale, which is basically a line that goes from 0 to 10 to be able to see this. When they were asked to evaluate it on the visual analog pain scale, the meditators said that it was quite painful, whereas the non-meditators said that it was, the non-meditators said it was quite painful, whereas the meditators said that it was hardly painful at all. So the other phases of this project, cognitive restructuring. As long as we believe that our pain is due to structural damage and we're reactive to every frightened thought that we have about that, as long as we believe that, well, then we're likely to stay stuck in the chronic pain cycle. But as you know, one of the things that these practices do is they enhance metacognitive awareness. Metacognitive awareness is a term that psychologists use to describe seeing thoughts as thoughts rather than believing in the content of the thought. When we practice meditation, particularly mindfulness practice, and we allow thoughts to come and go like clouds passing through the sky, we start to notice that many times anxious thoughts arise. And we learn how to not be reactive to each anxious thought, but rather to allow the anxious thought to come and go and see, there's another worried thought about my back. There's another worried thought. We also notice future-oriented catastrophizing. These are the thoughts that, oh my God, if this gets any worse, I won't be able to take care of my child. I won't be able to do well at my job. We start to see these thoughts coming and going, and we see the anxiety connected to them. We even notice what's called budgeting activity. This is where we think, well, I've already been active for 2 hours sitting, so I better not sit anymore. Otherwise, I won't be able to get through the rest of the day. So the more we practice mindfulness, simply the act of taking the attention out of the thought stream and coming back to the present moment helps us to develop this perspective on thoughts. We can see, oh, I'm having frightened thoughts about my back. It doesn't mean my back is damaged. Now, the next part is using mindfulness to resume a normal life. And this means getting back to normal activities. When we talk about psychophysiological disorders like chronic back pain, many of them involve kinesiophobia. Kinesiophobia, in English, it comes from the Greek, it means fear of movement. People become very afraid to use their bodies normally. And what we need to do is we need to return to using our body in the same way, whatever the activity is, several times a week. Let's say we want to take up walking. If we want to take up walking, you don't want to just do it once and then stop. Because if you do it on one day, after you walk, you're going to start thinking, uh-oh, did that make my back worse? And that worried thought will tense up the muscles and will make it worse. Rather, what we want to do is we want to do it every day, if possible, so that we see that some days are better, some days are worse, and that way we get over the fear. Then we can use mindfulness practice to work with the pain. When the pain comes up walking, we simply let the pain be the object of our attention. We breathe with the pain, we relax into the pain. And if we approach the pain mindfully, we're not too caught in our thoughts about the pain, we'll begin to see that the pain comes and goes on its own. And sometimes it's worse, sometimes it's better, but we don't have to control it so tightly. I'd like to offer you some handouts if you would like. If you'd like me to send you some information, and this will only make sense if you speak English, or if you read English. But if you read English, if you send me a blank email to handouts@yahoo.com, I will send you some information about what we're talking about here and some resources. And you'll also be on my mailing list, so you'll hear about mindfulness programs that are related to chronic pain and similar activities. Again, it's just an email to handouts@yahoo.com, and put on the subject line, just put Korea, and I'll know it came from here. So the last part of this involves mindfulness to work with negative emotions. Very often, when we're having chronic pain, we're cut off from painful emotions. I mentioned this before. If we are unable to feel our sadness, unable to feel our fear, or unable to feel our anger, every time these emotions start to come up, we will tense up to resist them. And you know, if you've practiced mindfulness, that all of these kinds of emotions exist in the body, right? We feel sadness in the body. We feel anger in the body. We feel fear in the body. And if we're doing open monitoring practice, we can simply bring our attention to what's happening in the body here and now. And by bringing our attention to what's happening in this way, we learn to be with it, to breathe with it, allow the sadness to come and go, the fear to come and go, the anger to come and go. And the more we can allow this free flow of emotion, the better able we are to be able to not tense up against it, so it won't feed into the chronic pain cycle. Now, other pain disorders operate very similarly to chronic back pain. The difference is with chronic back pain, the incidence of structural damage causing the problem is very, very low. With other pain disorders, it depends on the disorder. For example, a lot of knee pain and a lot of shoulder pain is not actually due to structural damage. Diagnoses such as a torn meniscus, for example, or a rotator cuff tear that are frequently given for knee or shoulder pain, turns out that rotator cuff tears and torn meniscuses are very common in the pain-free population. But of course, you need a good medical evaluation with each of these. But then we're going to follow the same steps: medical evaluation, cognitive restructuring, resuming normal activity, and learning how to work with negative emotions. Just before I end, I want to point to a problem that we have in the clinical care of this. Whatever the disorder might be, if ever something hurts in our body, we have two options about how to interpret this. These are survivors of near flu experiences. This is a joke. And this person is saying, I felt achy and awful, then suddenly it went away. And this is influenza here. I thought I was getting a chill, but as it turns out, I was just cold. I asked myself, am I a tiny bit nauseous? 5 minutes later, I felt just fine. Sometimes we really do default to the idea that it probably is nothing, and we go about our lives and we don't we don't take it seriously, and that turns out to be fine. Sometimes we worry that it's serious. She's reading the big book of horrible rare diseases, Lockjaw Monthly, everything you always want to know about scurvy, but we're afraid to ask, A Child's Garden of Maladies. Sometimes we worry too much. Trying to figure out, am I worrying too much? Am I not worrying enough? That can be a difficult calculation because, if a patient comes in and they say, yeah, I feel this lump in my neck, it's about the size of an orange, but I figured it was probably just a pimple. Well, that wouldn't be very smart, right? That's something that really requires medical attention. But then again, you don't want to be running down every little ache and pain because almost any ache and pain can turn into one of these pain cycles. And finally, I'd like to say, we want to be careful not to induce what's called new age guilt. And new age guilt comes from the idea that, oh, if so many of these different disorders are caused by problems, basically caused by stress, then I should be able to get over them. These are funerals from people who did different things. She was never the same after that crackpot diet. He pushed himself too hard. He moved to Florida and boom, 5 minutes later, he was dead. Sometimes people can't get better, even using mindfulness and rehabilitation, and we don't want to make people feel guilty or uneasy about that. Again, if you'd like to receive some materials about this and learn about other programs, just send a blank email to handouts@yahoo.com with the subject line of Korea, and I will send you those materials. And I believe we now have a little bit of time for questions and answers.
감사합니다. 우리 로널드 시글 교수님께서 우리 그 허리 통증과 관련해서 명상이 어떤 역할을 할 수 있는가에 대해서 발표해 주셨는데, 저도 이제 비슷한 경험이 있는데, 허리가 아플 때 우리가 책상에 앉아 있다가 일어설 때 우리가 이 허리에 다시 이렇게 자극이 가면 이게 아파질 것이기 때문에 너무 걱정을 하면서 일어서면 우리 몸이 거기에 과잉 반응을 해가지고 오히려 우리 허리를 더 아프게 해가지고 우리가 훨씬 더 많은 고통을 느끼는 어떤 그런 경우들이 많습니다. 그래서 통증은 우리 신체에서 시작됐지만 이 통증을 증폭시키고 이 통증이 계속해서 이렇게 가게 만들고 이 통증이 계속해서 우리의 삶의 일부가 되도록 만드는 것은 우리의 신체적인 측면이 아니고 바로 우리의 정신적인 측면이다. 따라서 이런 정신적인 측면을 우리가 어떻게 극복하는가에 따라서는 훨씬 더 어떤 이런 이 치료와 함께 많은 환자들에게 어떤 이런 우리가 허리 아픈 통증 같은 걸 극복하는데 훨씬 더 많은 이 역할을 할 수 있는 그런 측면들이 있다는 말씀을 해주시면서 어떤 그런 측면에 있어서 마인드풀 메디테이션이 많은 환자들에게 효과가 있었고, 사실 이게 본인의 경험으로부터 시작해가지고 자기가 여기 우리 명상과 심리치료 연구소를 통해서 이렇게 만나본 환자들과의 직접적인 어떤 대화와 자신이 가지고 있는 방법들을 적용해 봤을 때 효과가 있었다는 어떤 그런 이야기들을 지금 해주고 계십니다. I just briefly summarize.
You're welcome, and I just want to add the comment that
Okay.
in any individual case, it can be difficult to know what proportion of the pain is coming from some kind of structural difficulty and what proportion of the pain is indeed coming from the psychophysiological processes that I'm talking about. But you can always begin treating it as though at least part of it is the psychophysiological problems, and use mindfulness and the return to activity and see how far you get. And almost all patients will be willing to at least try that, saying, we don't know to what extent this will resolve your disorder, but it may resolve it to a good degree.
그래서 제가 이 궁금한 게 이제 강의하시면서 주로 말씀하신 거는 성공한 경우 주로 말씀하셨습니다. 본인도 이제 이 경험을 통해서 자기가 해보니까 성공을 했었고, 어떤 60세, 70세 된 환자들 이야기도 하셨고, 어떤 분들은 이 명상법을 통해 가지고 고통을 극복하고 테니스까지 이렇게 치는 분들도 있었다 말씀하셨는데, 제가 궁금한 거는 이게 사실 이 명상이라는 게 각각의 사람들마다 다 다르기 때문에 모든 경우에 있어서 다 성공하기는 어렵지 않은가 제가 그렇게 생각했는데 혹시 해보셨을 때 어떤 본인이 이렇게 이야기해본 명상법이 성공하지 못한 케이스가 있는가? 뭐 성공하지 못한 케이스가 있다면 본인이 생각하기에 어떤 이유로 그 경우에서는 본인이 했던 방법이 성공하지 못했던 것인지 거기에 대해서 한번 설명해 주시면 재미있을 것 같습니다.
Sure, that's an excellent question. And indeed, many times it's people cannot free themselves from this nearly as easily as I'm describing. Usually, the failure is going to come from one of two sources. Either it may be one of those rare individuals for whom the structural problem is most of the problem. The estimates here in the United States are something about 1% of the cases of chronic back pain are actually due to structural problems. About 99% are due to psychophysiological disorders. That's the best estimate based on the research here in the United States. But you could easily have somebody who is in that 1%, and that's going to make it challenging. The biggest thing that makes it challenging for people is if people are unable to shift their cognitive understanding. If somebody is wedded to the idea that they can never be free of the pain or the pain can never be reduced because there is something structurally broken, that can keep them quite trapped. And indeed, I'm very fortunate in my own practice as a psychologist because I only see those patients who already are thinking, I believe my mind is playing a role here. Millions of patients won't consider that their mind is playing a role here, so they would never come to see me. If you come to see a psychologist instead of an orthopedist, you're already understanding that your mind is playing a role. So that really helps me to get a start with people. I think everybody that I've worked with has at least been able to increase their range of activity. For some people, the pain doesn't get less, but when they start to see the role of the fear in their life, they can at least expand their activity somewhat. But I don't want to overstate the case. There are many people who just expand their activity a little bit, or there are some people who may meet with me once or twice and hear what I'm suggesting, and they think, that's crazy. Very often, what happens is somebody will come in to see me, I'll begin to explain about the chronic back pain cycle, and I'll try very hard to say, this is a psychophysiological disorder. It does not mean that you're imagining it. And then they will come back to the next session and say, the one thing I don't like is that you think I'm imagining it. It is very hard when you start to talk about the psychological factors to move people away from the belief that you're saying the pain is imaginary to understand that, no, you're describing it being psychophysiological, that the mind is creating emotional states which are contributing to the pain in a big way. But I've certainly worked with people who were very obsessive, who were constantly going back to the internet to Google more about their pain symptoms, and were constantly looking for some new theory of the medical cause, who did not get better.
질문이 없으면 제가 하나만 더 드리겠습니다. 아까 교수님께서 말씀하실 때 본인이 경험을 했을 때 이미 본인이 명상을 하고 있었기 때문에 어떤 본인의 이런 명상의 경험이 자신의 그 문제를 해결하는 데 도움이 되었다고 말씀하셨는데 많은 경우에 있어서 명상의 경험이 없는 사람들이 많기 때문에 어떤 그런 분들이 처음부터 우리가 뭐 사티파타나라든지 마인드풀 메디테이션의 좀 이렇게 복잡한 단계를 바로 하기는 어렵기 때문에 어떻게 아주 간단하게 본인에게 어떤 이런 심리적인 정신적인 문제가 왔을 때 아주 간단하게 적용할 수 있는 방법이 있다면 어떤 방법이 있는지 한번 말씀해 주셨으면 감사하겠습니다.
Most of my patients are completely new to meditation, so I have to do that. I have the same challenge myself. And usually what I will do is in the office, I will practice paying attention to the pain with mindfulness. So let's say it's a person with chronic back pain. I'll have them sit and close their eyes and perhaps begin paying attention to the rising and falling of the sensations of the breath in the body. And then at a certain point, they will usually say to me, my back is hurting. And at that point, I'll say, okay, leave your eyes closed and simply begin to let the breath be in the background and bring your attention to the sensations of the back pain. And I will spend the session helping them to see every time that they tighten up against the back pain, every time that they have an aversion response where they're trying to push it away. So I work with them in the office, moment by moment, learning how to, instead of constricting and fighting and trying to get rid of the pain, to open to the pain. Very simple exercise we can all do here together if you would join me. Please make two fists the way I'm doing and hold them up so we can see them in the camera, and squeeze your fists very, very tightly as though you were very angry or frustrated, and feel the anger and feel the frustration, and then do this. And notice what happens to the feeling of anger and frustration. Notice how in that simple movement, it changes. I will do that with my patients to help them to see the role that emotions and the body, how they work together. I'm a psychologist, yes, but in many ways I'm a teacher. I'm trying to help them understand psychophysiology. And very often I don't introduce formal mindfulness practice. I'm not gonna have them sit on a cushion for 45 minutes. Many of them would not be interested in that, but I will ask them to see if they can be with their pain in a different way, and especially in the office to separate the two arrows, to notice what the constriction, the fighting, the hating, the aversion is like, and what the letting go and just being with it is like. And almost always patients will notice, oh, my pain is still there, but I don't feel as miserable. I don't feel as much suffering. And just noticing that a little bit gets them interested in pursuing this.
예, 감사합니다. 우리 참가자 중에서 질문이 왔습니다. 두 가지 질문인데 첫 번째 거 먼저 하겠습니다. 명상을 너무 오래 하면 사람이 무미건조한, 심지어는 감정이 없는 사람이 되어버린다는 느낌이 있는데 거기에 대해서 어떻게 생각하십니까?
I don't actually think that is what happens with practice. Many people, well, let me say this differently. Anything that we do in life can be done as a psychological defense. We can watch television in order to not feel our feelings. We can take drugs in order to not feel our feelings. And some people will use meditation. They will use concentration practice, just focusing intensely on an object to try to get rid of emotions. But as soon as somebody shifts from concentration practice, samatha practice, or what we call in the West now, focused attention, when you shift from that to open monitoring, to actual mindfulness practice, to vipassana practice, in which you're opening to whatever sensation is arising in the body, we start to notice sensations associated with feelings. We start to notice that, oh, there's sadness, oh, there's anger, oh, there's longing. As I understand these practices, when we practice with an open heart and an open mind, and particularly when we practice compassion as well, we don't become emotionless. Rather, we feel the entire range of emotions, and we feel them even more vividly. There's a story about this that comes from Tibet, and it comes from Tibet before Buddhism reached Tibet. They had a mythical kingdom back then called Shambhala. And in the Shambhala kingdom, the highest achievement was to be a Shambhala warrior. And a Shambhala warrior was not a conventional warrior with knives and shields and spears. A Shambhala warrior was a warrior of the heart who had the courage to feel all feelings. In fact, the metaphor that they use to describe the Shambhala warrior is going through the world like a cow without its skin, with every nerve ending exposed, exquisitely feeling the suffering of others, exquisitely feeling the full range of human emotions. I believe where these practices lead is not toward a flatness, but they lead toward a kind of equanimity which allows us to feel all of these different feelings, but we do not feel compelled to act on them. We don't feel reactive to them, but we feel the full range fully.
예, 감사합니다. 다음 질문은 저희 어머니께서 80세이신데 대상포진으로 고생하시고 있고 진통제로 이렇게 버티고 있는데 혹시 명상이 대상포진과 같은 거에도 효과가 있다고 생각하시는지 궁금합니다.
The practices are not going to make the shingles go away, but they can change the relationship to it. Here we're back to the story of the two arrows. The first arrow is the moment-to-moment sensations of pain from wherever she has the shingles. The second arrow is the reacting against it, the tensing against it, the hating it, the wanting it to go away. Mindfulness practices are not going to eliminate or reduce the first arrow. The shingles sensations are going to be there. In fact, when we begin to use mindfulness practice with pain, we actually experience the pain sensations more vividly. They become more intense because we have more refined consciousness. I once gave a talk about mindfulness at Google, the company in California, and the engineers at Google described the goals of mindfulness as developing higher resolution consciousness, more pixels per square centimeter. We become more sensitive. We feel it more. So your mother would feel the pain more vividly, but if she's able to relax the aversion response, she may suffer a lot less. She may find that she's not constantly fighting against the experience. And the more we can breathe with and let go and be in this, the better. The difference between the shingles and chronic back pain is with shingles, there's a definite structural cause. There's the inflammation of the nerves caused by the infection. And they're going to continue to fire. With chronic back pain, sometimes there's a structural cause, but very often it's just the cycle that I described to you. So with chronic back pain, sometimes the pain goes away completely and we're free to live our life normally. With these other disorders, what you get to do is you get to reduce the reactivity to the pain, the resistance to the pain, and then there's less suffering. But of course, there's still going to be some pain.
감사합니다. 다음 질문은 본인이 이 그 상담을 받으러 온 사람의 이 치료를 위해서 어떤 심리적 측면뿐만 아니라 의사들과 함께 협업을 해서 어떻게 이렇게 치료에 성공한 케이스가 있는지 궁금해하십니다.
Almost all of my work is in collaboration with other doctors because, as I said earlier, you need a medical evaluation to make sure that the person doesn't have a tumor, to make sure, for example, in the case of back pain, that they don't have something like spondylolisthesis where the spine is actually fractured and it would be dangerous to move normally. You need to make sure that it's not kidney disease that's causing the back pain. So we always need to work with doctors, and my best results are when I'm working with doctors that understand psychophysiological responses. Physicians who understand that a great many times, these pain syndromes are actually caused by the chronic back pain cycle that I showed you. Because if the doctor understands that, then the doctor can say, I have evaluated you, we have done the necessary imaging, we know that there is not some serious structural problem causing this, there's not some other disease we have to treat, and in fact, we know that it would be safe for you to resume all of your normal life activities. So I want you to work with the psychologist to do that, and to learn mindfulness practice, understanding that it is safe to do so, and you don't have to worry that there's some other serious disease happening here. So the collaboration between the people, medical doctors who can give that reassurance, and mental health professionals who can help people work with their fear, help people work with their thoughts, help people work with their reactivity to the pain, is actually working as a team is the most effective way to do this.
질문이 하나 더 있습니다. 통증의 정도가 아주 심한 분 같은 경우에 어떤 이 마인드풀 메디테이션을 권하는 것이 좋을 것도 같은데 아주 심한 경우에는 사마타 같은 명상이 훨씬 더 효과적이지 않을까요?라고 질문하시는데 모르겠습니다. 교수님께서 사마타도 조금 하시는지 안 하시는지 모르겠지만.
It all depends on the person's capacity to tolerate it. People vary tremendously in their ability to tolerate pain. We know this from simply doing studies. You've probably heard of the disorder called fibromyalgia. And we used to think that fibromyalgia was affected these particular trigger points on the body. And fibromyalgia involves pain all over the body, fatigue, difficulty sleeping. It's a whole collection of difficulties. We've learned in recent years that fibromyalgia is actually a sensitivity to pain. So if you take somebody struggling with fibromyalgia and you do an experiment, let's say you take their thumb and you put it in a device that applies pressure, they report pain at half the level of pressure that a normal person would. They are just very reactive to the pain. So when somebody is at a 10 on the scale of pain, it's hard to know, is it simply somebody who is very reactive to pain so that the same stimulus would evoke more of a reaction on their part? Or is there something more difficult happening in their body that's causing it? This is always an experiment. In the short run, distracting ourselves from the pain, like taking a walk or doing something so we're not so focused on it, can make it feel better. In the long run, having the capacity to do samatha meditation actually is very effective. But we really have to see in each situation with each patient what their tolerance is. Because if somebody is very, very reactive, they're just going to become so frightened and overwhelmed that we're going to traumatize them. And we always want to work within what we call the zone of safety or the zone of tolerance, to not give a person a challenge which is going to be so great that it becomes traumatic for them.
예, 우리 교수님께서 완전히 우리 통증 상담해 주듯이 아주 친절하게 답변을 잘해 주셨습니다. 오늘 아주 친절하게 많은 답변에 잘 말씀해 주시고 아주 좋은 강의로 저희들에게 명상이 어떤 역할을 할 수 있는지를 설명해 주신 로널드 시글 교수님에게 큰 박수 부탁드리겠습니다.
Thank you so much for inviting me.
네, 그러면
I
다음
hope to come there. I hope to be able to visit in person someday. I was in Korea a number of years ago. I would love to come back.
So when COVID-19 get the situation is getting better, definitely you will come to Korea and you can see us face to face, have another conference together.
I would be honored. Thank you very much.
감사합니다. 감사합니다.